Afternoon, everyone. Welcome to the last of 6 free open forums, Telemedicine Now and How, made possible by a grant from the California Healthcare Foundation. Today's theme is emergency medicine, nursing home residents, and tele-palliative care, past, present, and future. And our very special guest is Dr. Claritza Rios. The forums are presented by CSU Shiley Institute for Palliative Care in partnership with ResolutionCare, pioneering telemedicine in Northern California. I'm Jennifer Ballentine, Executive Director of the CSU Shiley Institute for Palliative Care, and I will be your moderator today. The Institute is a workforce initiative of the California State University system, offering online education in palliative care for frontline clinicians and healthcare organizations. And now I'll introduce our facilitators. Dr. Michael Fratkin is a builder, innovator, and dreamer who approaches life and the practice of medicine with love and respect, incorporating principles of value-based payment, technology-enabled service delivery, and interprofessional team integration. Dr. Fratkin and his team have created ResolutionCare Network to build capacity for high-quality, home-based palliative care in rural Northern California and beyond. Dr. Brian Mistler is Chief Operating Officer of ResolutionCare, a benefit corporation committed to leveraging telehealth technologies to deliver quality care to a racially, economically, and geographically diverse population that includes large areas of rural Northern California. Dr. Mistler is a healthcare leader with a deep understanding of the strategies that drive business impact and individual change. Dr. Claritza Rios is an attending physician at Highland Hospital and has been involved in a number of entrepreneurial efforts regarding telemedicine and the delivery of care through mobile device. Dr. Rios is a dedicated physician with extensive experience in emergency and internal medicine. She found her calling further specializing in palliative care. With this broad level of expertise, she recognizes the profound need for access to care for people and especially high-risk populations. This brought her to telemedicine, where she has built programs and processes to bridge across gaps. So with that introduction, without further ado, take it away.
Well, I just want to say how excited I am that Claritza has joined us. I also want to say I'm a touch sad that this is the last of our series of 6. I see some of the participants in the Institute Masterclass are with us today, and I appreciate that. There'll be another iteration of the Institute of Palliative Care Masterclass in Tele-Palliative Care. But beyond that, Claritza and I have been in communication over the last 5 or 6 years, and one of the things that I love about her is that she has this combination of love and fun, as well as competence. And these conversations that we have had over these last 5 years while we built what we were doing and she was building what she was doing have been informative as we both were gaining the experience that is the only real thing that can teach you how to do this work. And so we've had a lot of fun talking about it and learning about the different ways that you can deliver palliative care value, which really generalizes to any healthcare value. To different settings. We're mostly in the home, and she can tell you a little bit about the work that she's done previously. But take it away, Dr. Rios.
Hi, everyone. So thank you for the introduction, and thank you for the invite. It's really nice to be here. And I think it's wonderful to create these opportunities where we're teaching each other and learning from each other about the work. And this is really important work, especially now with what's happening with COVID-19. Telemedicine is really this wonderful vehicle where we can really reach these patients that are really at risk. And that's kind of been my beacon, right? Like I'm always looking to find at-risk populations and marginalized populations and help support them. And that's kind of what brought me to bringing palliative care to skilled nursing facilities. And specifically, as many of you know, there's about over 2 million, 2.5 million ED visits from skilled nursing facilities a year to emergency departments. And so with emergency medicine visits and physically patients being in the emergency department, there's a ton of hospital-related sequelae that ensue. And that could range from worsening cognitive function to increased risk of infection, getting the actual infections while they're in the hospital or upon return to the skilled nursing facility setting. And because of all that, you have decreased functional status. And as we know, functional status is tied to mortality, is tied to people doing well. And so keeping patients in their environment and the familiar environment is really important in keeping those sequelae at bay, right? And so it makes total sense to want to bring the emergency department to the patient's location. And there's many programs doing similar things at home with Tele-Paramedic care. And a lot of this work is wonderful, right? But by bringing the emergency department alone to the bedside, you're kind of missing an opportunity to educate, support, and maybe even course correct, unless you have really well-trained emergency medicine doctors, which is sort of also part of the work. The emergency is often an indicator of overall decline. And so it's important that marrying palliative medicine and emergency medicine into a model like this is important, because you can identify patients who are at risk for an emergency prior to it happening. And that way you can set goals about what is acceptable and what isn't acceptable during an emergency. And after the emergency, you can reassess goals and help support the patient if after that emergency there's an opportunity for course correction.
Yeah, Claritza, what I've always, the way I've told the story of your work previously was that an emergency medicine intervention was designed to take this care to people in nursing homes. But then there was this discovery that we didn't know what people wanted. We didn't know how they felt. We didn't know what their goals were. We didn't understand their preferences. And golly gosh, maybe this interesting synergy between putting palliative care and emergency medicine together and then taking it to where these people live. So that's always been a really exciting part of your work to me. Can you tell me, let me go ahead and I'll spit out one of the questions I suspect that others in the caller have. And then I also want to do what I always do, which is to encourage everybody to have the courage to put on their cameras, because we do love so much seeing your faces. We really do. In fact, I'll even just admit that this is a bad hair day for me too. So that's, that's why I'm wearing a hat. So put something on your head, change the lighting, whatever you have to do. But I want to see your smiling or other wise faces too. So the question I had for you, Claritza, people think a lot about old folks and the population of nursing homes as being, heavily skewed towards old folks, or people that have cognitive impairment and stuff like that. That seems to be kind of an obvious barrier to using telemedicine. Can you talk about some of the things that you've learned over the years to overcome those kinds of barriers?
So I think when we came into the nursing home, and I will tell you that I was a telemedicine convert after doing the work. So I want to bring that into the conversation as well. And you brought up this idea of like, well, duh, these people are having an emergency, but what are their goals of care? I came into Call 9, which was the company that was doing the emergency skilled nursing facility work as an emergency medicine physician, trying to, I've always been really into technology, and it was sort of this cool opportunity. And I was curious about telemedicine, but I'm very touchy-feely. I'm all heart. And so in my mind, there was no way that I could engage someone this way. And I came to it when I had an emergency case where I was like, I never can take off my palliative care hat when I'm in internal medicine or in emergency medicine. I'm wearing all the hats all the time. My approach is slightly different, but depending on the venue, but for the most part, can take off the hat. And basically went to see a patient who was in APE, in acute pulmonary edema from worsening heart failure, likely also septic, and was actively dying. And his wife was at the bedside, not wanting to send him to the hospital, but not knowing what to do to help his transition be a comfortable, peaceful one. And our technology had failed. And so my colleague on site, I was in California, she was in New York, in Long Island, and she and I FaceTime. And through a tiny little iPhone 4, I think it was, I did a palliative care consult with this patient that I had just seen. And, you know, I was done. I was like, I don't know what I have to do, but I'm not only going to do this, I'm going to build out a program because this was magic. And it just really helped the family member come to a place of peace and feel less pressure to have to make decisions because we were guiding and helping and supporting her. And so that's the anecdote. But that is, as we go into nursing homes or went into nursing homes, one of the big things was the intro, right? And getting to patients and meeting the patients and using the novelty of the robot and the novelty of the video and the novelty of this space walking around to really engage them prior to us coming into for consultation. And so introducing the technology right away was really important. We underestimate how awesome older folks are, I think, in general, and how cool they are with change. And so I think that's another thing that we need to just shake off. Like, people step up to the challenges put in front of them, and especially in change. And many of these people are coming into nursing homes. So a lot of change coming at them. When you introduce things from a place of yes and warmth and awesomeness, people take to it pretty well. And I always say it's about this. It's not about whether it comes in an iPad or in a robot. It really is about what comes out through that speaker. And older folks really take to that. In folks where there's cognitive impairment, early introduction is really important, but gathering the troops around you as well. So as you're implementing these programs and these services, making sure that you have a really good understanding of what the patient's limitations are, and you know what their cognitive dysfunction is, and whether the technology is going to add more stress or less stress, and that way you come into the consult with more just smarter, right? And so making sure that your nurse manager and your bedside nurse are involved in the decision of whether a bedside consult makes sense, and then gathering all the appropriate stakeholders to come into the conversation. So making sure that you get family members early, but even patients with some mild cognitive dysfunction, I think if you introduce things early on, they remember. And
yeah, no, that's it. Yeah, one of the things that Brian's been talking about with me is that the energy with which we bring forward an opportunity has a lot to do with how that opportunity has been received. As we've done 5 of these sessions, now we're into the 6th, I may have given a few bits of knowledge and information to people, but actually what I hope to have done is I've invited you to explore this whole new space, and the enthusiasm with which you tell that story and your own sort of conversion experience is the kind of thing that should encourage people to step up into the change with some curiosity and stuff. So good. Jennifer, could you take us into a few of the questions?
Yeah, I'm actually going to ask one of my own to start.
Oh, go ahead.
Just this morning, very early, I was on a call. We were talking about the importance particularly in the current circumstances of nursing facilities circling back around to their residents to ask them, again, what are your goals? What are your preferences? And in particular, if you get COVID, is that different from your regular, goals and preferences, and what do we do? And along with that, the assumption of a desire on the part of many nursing facility residents to not go to the hospital and not get that very, very invasive and likely not particularly effective treatment. But can the nursing facility really care for them as they're dying, potentially, in the facility? And how does that impact the rest of the facility? And this concept of the emergency room coming to the nursing facility is not one I think that anyone on that call had really encountered before. So I wonder if you can just talk about how that came about and how it works and how you see it working in the current circumstance for nursing facility residents who don't want to go back to the hospital, but the nursing facility is worried and the family perhaps is worried about how this is all going to turn out.
And so one of the things that's important to speak to is how we were set up. Because I think you're bringing up a really good point, which is we need to recognize that skilled nursing facilities are under a ton of stress. Skilled nursing facilities were really meant to be the place you sent your 60-year-old marathoner dad after he had a knee replacement to go get rehab and to get, stronger, because he was strong to begin with. And what they've become and evolved into, and of course it's not been the large majority of the patients were in all knee replacements, but a big chunk of them, especially for short stay rehab. But the vast majority of the patients are patients with a ton of comorbid conditions who have a lot of need. And so the structure of the skilled nursing facility is one that is really, really not meant to do this. And they're taking, as hospitals are getting dinged or slapped for, having bounce backs for infections or things of this nature, skilled nursing facilities are taking sicker patients back after hospitalization sooner than they probably should. So staff is already overstretched. And so what our program did, Call I, was place a paramedic on site at every facility. And they were a set of extra hands that were vetted by the Call I team. And so they knew urgency and emergency at a high level. And so that was a really big help and support for this facility. As you can imagine, that is a huge cost. And so when we think about, and sort of Call I is no longer here, and cost was a really big issue with it. And reimbursement was an issue now with COVID, telemedicine, everything's sort of evolving and changing, and who knows what'll happen. But one of the things that we quickly learned was that we also needed to make sure that we were mindful about resource allocation at the facility. And so that if the paramedic wasn't on site, how can we use the nursing staff that is there and protocolize things so that nurses felt trained up, because many of them had not rotated through the emergency department, been in acute care type settings. And so the movement is to train nurses up to understand that by helping a patient transition to the end of their life, you are using a ton of resources, right? But you're doing it for delivery of high quality care, right? And so that was sort of a big thing. Nurses were like, oh my goodness, I'm going to be giving morphine to someone. That's so intense. That's so hard. The conversations didn't usually go like that. It was more like, oh my God, we're going to expedite somebody's death. And so we needed to train them to feel that it was hard, not that it was criminal or problematic in some way.
And accompany them, right? And accompany them, not just train them, but accompany them.
Train them and handhold, at least initially for, I would say, the first year, of really supporting the nurses and saying, we're going to go ahead and give this 5 milligrams of morphine to this patient. We're going to hang out at the bedside, and I'm going to be here in this little robot until it takes effect. And you and I are going to have a conversation about what this means and what we're doing. And that was really big. But the resource allocation piece, as we were thinking of becoming more cost effective, became a big issue, because you are asking these folks to do things that are, you need to train them up, you need to support them, and also you need to have them think about is putting in a Foley, hanging the antibiotics, doing the deep suctioning, getting RT at the bedside and hovering over them, having like PT on site. Those are a ton of resources. Can we use a lot of those, but in a lesser, less annoying to the patient way that meets their goals, and it's actually better quality care? And that was sort of this like aha moment for people, and a big shift. And the minute we had that one good death, or that person who I gave like 40 of morphine over 4 hours, and then they were like high-fiving me going like, oh my God, I feel awesome. Immediately, nurses were like, oh, wow. And staff and attending physicians, the SNFists, the doctors that are trying to get to 50 patients in a SNF, we're all like, oh, that's what that is. It's about helping people live as comfortably as possible for as long as possible. But to Michael's point, you can't just do like, morphine doesn't kill people and then walk away. You need to sit there, you need to support them. And so it does take a little bit of hand-holding, but that is with any innovative new thing in medicine, right? We want to make sure that we're educating, mentoring, supporting. It is, I think, an apprenticeship, right? And so you need that mentorship.
And that's what we're doing today. I mean, the nursing home is one of them, many different settings, and each of them have their own nuances. But what Jennifer's question really highlights for me is we do a lot of care fairly automatically and with very little consistent and refreshed understanding of what the people we care for really understand and want from their care. And I think the fact that we're under the umbrella of the Institute of Palliative Care is kind of requires us to draw attention to that. And I think the marriage of emergency medicine intervention with palliative care is exactly that. You have to, at the same time as emergency is unfolding, or hopefully slightly before, be in the conversation with people about what they do and they don't prefer as far as intensity of treatment and the kinds of interventions and relocation to other settings and procedures and all that stuff. Some people really want, the full Monty, the whole thing. And other people don't want much of any of that other than to be seen and heard and comforted. And you just don't know what they want unless you ask.
And I think another thing that's really important to speak to is that one could assume, because somebody's going to short-term rehab, or that somebody is now a resident of a skilled nursing facility, that there has been that meta big picture discussion about what is acceptable for us to do to their body and what's not acceptable to do to their body. How they want to be cared for or how they do not want to be cared for. The reality, unfortunately, is that in my experience, seeing thousands of patients in skilled nursing facilities throughout the state of New York, that is a very, very bad assumption to make. It's to the level of shock. We're like, of course I don't want this. What are you talking about? And the full code by default that patients come into skilled nursing facilities is not because there has been this in-depth discussion. And you would think that as a hospitalist, palliative care attending, and an ER doc that I would know that, but it was a real big shock for me. That
do you guys know that? Did you guys know that most people in your practices, even those with serious illness, have not had complete or fresh or even topic specific advanced care planning discussions. Does that surprise you guys? I'm seeing a lot of heads go like this. It does for Anne, who's a therapist. Go ahead, Jennifer, take us into some of the other questions.
Yeah, so I have a question from Nadia Dimitrov. This is for both of you. Are you familiar with the physician assistant model in the SNF to function as the primary care provider or on the interdisciplinary team? Did I get that right, Nadia?
Yeah, I go ahead, Claritza, because you work more in the nursing home environment.
I'm sorry, I didn't hear the question so well.
Oh, the question is using physician's assistants or nurse practitioners as an integrated part of team-based care in the nursing homes. Is that something that was a part of what you were up to?
Yeah, there was, and we found most success with people who were bedside nurses or people who had extensive practice prior to coming into the skilled nursing facility setting. We struggled a little bit sometimes with fresh graduates who had not had clinical experience, but had sort of the DNP or some sort of NP degree. And there had to be a lot more support there, but some of my best experiences, and I learned so much from Kelly, this particular nurse practitioner at one of the facilities, who had been a bedside nurse for like 25 years. And little things like wound care, which I'm becoming better at, but definitely not, it's definitely a growth area for me. And palliative wound care, communicating palliative wound care to families, just such amazing knowledge. But yeah, I think it's the more the merrier, right?
Yeah. Well, I mean, I'll take it one step further. Our medical staff, the providers we have currently are all physicians, but haven't always been. And we've worked with some very talented PAs and nurse practitioners. But I think the word assistant actually inspires me to go a little bit deeper in the concept. When you create a transdisciplinary team, a team of individuals who bring their license and their knowledge base, but also bring their humanity, you start to see that a huge amount of the value lives at the sort of base of the pyramid. And so we have a role in our organization we call community health workers. Other programs extend their teams with people, lay navigators. Promotora is the sort of the old school kind of emergent the sort of genesis of people who are part of a community who may not have had the privilege that takes them into the educational processes that most of us have, but have learned and maybe were born to be caregivers. And so we hire and train community health workers to help us round out our team. And sometimes what they're doing is as simple as holding an iPad or facilitating video conferencing, but actually quite often they have a depth and unique quality to the relationship with the people we're caring for that give enormous and important actionable insight to the more overeducated members of the team like me. So they really are intimate. And when you think about wrapping care around a person as the person they are, the medical expertise, the knowledge base, the technical details, they're important, but they're not everything. And sometimes people who didn't finish high school have more insight into the human condition and the lived experience of people than people like me.
So we have a question in the chat box from Paula Matelli. Paula, I'm going to actually unmute your mic so you can ask it, because I'm not sure entirely what you're getting at. So go ahead.
At issue, I've had experiences where families have brought recording devices in to goals of care sessions. And in that moment, I felt it to be very uncomfortable and inappropriate. Looking forward and the role of Tele-Palliative Care, is there a possibility that the sessions would be recorded to help with charting and therefore coding and billing? And then if there's a recorded session, what would that look like as far as a medical legal issue if the standard of care is not being upheld as perceived by the patient, a family member, or the physician in terms of the patient and how they're participating in the care plan.
Great, Paul. Well, I have a dream. I'm gonna give my I have a dream moment. I have a dream that all the documentation that is required of me in a clinical encounter amounts to pushing record and stop, and then I sign it. I have a dream that artificial intelligence will throw out all the BS that are a part of my encounters and be able to recognize the actionable, important information, that all that I really need to add is communication, either to family, to person cared for, to my team members, in very bullet point fashion. If you're interested in what happened, here's the document. If you're interested in where we're going, here's the 3 things I want you to do. Signed off, move on.org, on to the next one. I have a dream.
I'm working on that right now, Michael, so we should talk.
Oh, good, Claritza. We'll talk.
I've been recorded all the time. Sometimes somebody will sneak a phone and I'm like, are you recording? Why don't you turn the phone towards me so they can see me? And it automatically disarms people. But I think you're bringing up a good point. It's like what some of the stuff is uncharted territory, right? I welcome it with the understanding that it comes at some risk, and I wish I knew more about how to speak to that, but I don't think there's enough legal it just hasn't happened enough, I think, in my experience and speaking to our lawyers, to really speak to like where the lines are drawn and kind of how it's going to evolve. But I'm a big fan of disarming people by saying, do you want to record this? I'm speaking quite a bit. Do you want to record it so you can then send it to your family member? And automatically it's just like it shifts sort of their focus. And I think, you know, that speaks to the sort of the bigger question, which is sort of if people, and I'm sure we all do this, right? Because obviously you are my people, palliative care folks. But when people are engaged, if they feel heard and they feel like they're part of the decision making, there's less how, you know, you did something that made my 99-year-old cognitively impaired EF of 10% mom die, as opposed to at 99 years old, this was going to happen. And, you know, many things happened that contributed to it, but probably it wasn't that, you know, I gave like 10 cc push of whatever, you know. But anyway, that's without tangential.
Yeah. No, it's super cool. You know, there are all these sort of nuanced questions about, you know, technology and recording, and then there are these questions related to setting, talking about nursing homes and the combination of palliative care with emergency medicine. And then there's what you all are doing wherever you all are doing it. Are there issues that you're facing as you tiptoe into the use of these technologies to communicate with people and connect with people? Are there issues that you're facing that you found some unique solutions to, or are running into a brick wall about? Can you bring forward, is anybody that wants to tell what their experience is, a little report from the field? Don't be shy, folks. All right, well, let's see. With long-term care, this is from Aaron Salvador. With long-term care being hit so hard with COVID, I'd like to work to help long-term care with communication, teaching, having the more difficult goals, conversations with patients, families, and care providers if they wish. Are there any models people recommend or are using in this capacity? I think that what Claritza has been talking about has been the Call 9 model. And what I can tell you is that around the country in small little organizations, maybe Claritza even knows about certain developing network solutions in this or that small area. There's a lot going on, and people are leaning into trying to be a part of a COVID-19 response. That's tricky to do. It's tricky to put together the partnerships quickly that are necessary for integrated service to be delivered. We know that I can deliver Claritza, Jennifer, Brian, Damon, and myself and Maria into your home offices like this. So why couldn't we deliver palliative care value directly to where these folks need it? So it's not a technology issue. It's more of a primate management issue. Human beings and their organizations are delicate in how they move and how quickly they move to do something that's actually quite doable. Jennifer and I and California Healthcare Foundation were able to very quickly put something together that has demonstrated value over these last 6 weeks, because it was really relatively simple. We kept it a lean little project so that we could invite you all to come tell us what you were dealing with and to give our enthusiasm for the new process.
You said it was relatively simple, easy for you to say.
Yeah. Fair enough.
A lot of credit to the team for making it look so simple.
There you go. Exactly. Well, that's true. That's true. There's always some heavy lifting. There's always the rolling up the sleeves. There's always the who's going to do this or that. How do you link up all the elements of the workflow? So I guess the answer that I would give to that question is, who's in charge of the long-term care facility that's closest to you? What's their perception of unmet need? How well do you know them? How well do they understand what advanced care planning actually could mean to the quality of the experience of their residents? What are their thoughts and feelings and ideas about telemedicine? It's not the same, I guarantee you, than it was 2 months ago. So there may be opportunities right in your backyard to do exactly that, to lean right in to the care facilities that are close at hand. We have put a lot of devices out into the hands and homes of the people that we're caring for. If you've got a device that you can put to work, maybe it's worth just jumping into it and seeing what you can accomplish and what you can demonstrate is possible to all the stakeholders around those projects.
We have another question here. Home care nurses are allowed to do video visits and get reimbursed, but they're not using it. Managers are not really encouraging it. Any thought about how to get them to try it?
Well, I'm going to speak to my manager in the room. Dr. Mistler, could you please take that question?
Sure. Well, I'll start with it, and then I want to hear what Claritza has to say as well. But my sense is that you might be talking to the wrong manager to start with. At some place in your organization is somebody who's deeply invested in the bottom line, and it very quickly becomes clear that if you can see 3 people in an hour, or in 3 hours, and versus by video versus 1 person and an hour of driving and an hour of driving, it makes sense for the bottom line at a really high level. But that's not enough. The next step, I think, is to find the manager at the intersection of those two things. So the person who is in touch enough with the bottom line that they understand the advantage, but also in touch enough with the clinical service delivery that they have credibility with the other clinicians and that they understand what it looks like on the ground. And if you can find that champion, maybe it's not a manager, maybe it's somebody parallel in the org chart, then they can be an ally in helping talk about the advantages and transform it.
Claritza.
I think I hear 2 problems. Possibly I'm reading into this a little bit, but one is people think that video calls are just okay, that they're like suboptimal in some way. And so I think if you can show that it's not just good enough care, it's good care. And that if you're not driving an hour, that you can then see more patients and then you can do good care for 2 extra people that afternoon, that people are like, oh, duh, right? I was in California and could see people at 7 different skilled nursing facilities throughout the state of New York. And then, of course, I had an amazing team that like made the schedule work, but that's amazing. And 2, it's also this fear that technology is hard. And and the connection and the receiving end. And so I think, again, if you can show the nurse and the patient, so both people on each end of the device, that this is doable and that it can be a meaningful interaction, then I think that you have a win.
Yeah. I mean, a lot of what I do is I trick people into evaluating the communication channel by jumping onto a video with them. Like, and now in COVID-19, you don't have much choice. If you're going to talk to the manager or the person on the org chart that seems the strategically best position, well, they're going to have an experience of video conferencing when they talk to you. And if you manage that effectively, with appropriate light, with a sense of directorship. Brooke Calton was with us a couple of weeks ago, and she brought us this concept of that comes from our training to set the stage at the bedside, but she's actually setting the whole scene from a director's point of view. The idea of getting everybody settled, getting the device set down and propped up, getting all of the technophobia, techno anxiety, and fuss handled before you then begin the encounter. I do that every time, even almost without consciousness. My little joke about my hair, my little engagement with individuals on the screen, my teasing you into turning on your videos. This is all about settling down so we can actually then turn our attention to each other and the topic at hand to really address. When you do that with a manager who has their pre-existing biases against the technology and demonstrate, you know what, actually it works. They get that experience. You don't have to tell them, you've experienced it with them, you've shown them. So it works on managers as well as sick folks.
So the next question is, it follows on very nicely from that. Dorothy Harston says that she's just started palliative care home visits on Microsoft Teams. Had to jump in and do it, expecting glitches. But her biggest concern is how to do any type of physical exam.
Claritza, you have more experience, and you guys used some remote monitoring gizmos and had a paramedic on the ground, right?
Yeah, so a couple of things. I think if you're solo, getting really comfortable with, one of the things that we've learned is that use what's available, right? And so often, and as I advise other startups and other telemedicine companies, one of the things that we encourage people to do is use the resources you have. So is there a family member that can scan to the legs and literally push on that leg and say, well, oh, that's fitting edema as opposed to just like a nice juicy leg from other reasons, right? Did I just say juicy leg? I did, sorry. You know, if you have a electronic stethoscope, great, fantastic. Those are not 100% either, right? So how important is it for me to know that it's wheezing versus rouse when somebody's breathing at 35 and has a history in the EF of 10%? Probably not the most important thing for me to know. But if I know that they're breathing at 35 and I see it, right? And so that visual is really important, but use what you have around you. So if I can't really get, gosh, I don't know what's going on with the patient, let me walk them. Let me ask them to do different things. Let me get the family member to do something else. If you're talking about billing, and that's a different story. But if you're speaking about what it is that you need, the visual is a ton, at least for me. And you know, we did, like the paramedic would be in a room and they would have the pulse ox, and somebody's pulse ox would be at like 85%. And I'm like, I don't need the pulse ox. Let's get the BiPAP on the patient because they're clearly in respiratory distress. And then you can sort of take a step back once you stabilize them and look at the legs and see that it's edema or, that's what I'll say. So, and respiratory distress, that's a helpful exam finding, right? I mean, and in a respiratory rate of 30, accessory muscle use. I don't need necessarily the lung exam to to have the slam dunk assessment of the cardiopulmonary picture.
It's interesting, you know, the physical exam is one of the great arts of medicine that sort of traditionally has tracked through, and there's the great champion of that in the modern world is Abraham Verghese, who's just an incredible, complete physician from Stanford, and writes a lot about the physical exam as a ritual, as a ceremony, as a mechanism that is perfectly well suited to the exam room. It's called an exam room for a reason, right? That's the temple in which the ritual occurs. And there is huge value in the physical contact and the maneuvers and the touch and everything else. However, it turns out that in the 21st century, most decision-making, 90% of decision-making, is not based on the physical exam. It's based on either observation or information that you can glean by asking people. This question, though, has been lurking in the background, and I've had intention to do some background research on it. And it turns out just before I was about ready to maybe get to that place in my inbox, a dear friend, Dr. Robert Moore from Partnership Health Plan, put together a really pretty comprehensive set of videos that are available to everybody on YouTube that talk about all of the many things that you really can do with physical exam, in terms of lung exams, in terms of neurologic exam, in terms of orthopedic exams, and all the rest, and just thought through about the many things that are available to you if you want them. I'll ask, we compiled it and I put it together for the masterclass in Tele-Palliative Care, but I hope it's okay, Jennifer, if we just send that out to these 64 participants so that they've got it. They're all hot linked. There's one general piece from Stanford, which I think is really pretty good, a 15-minute piece. But then there's all these other choices that you can look at and get a feel. And as you go through them, you'll discover there's tons that you can do, both by observation, as well as you can coach family members to poke and push and prod and change the location of the camera to do really a pretty comprehensive physical exam for just about any purpose. So we'll send that along.
Right. Dorothy, I unmuted you. I just wanted to make sure that you that was your question, if you had any follow-up.
I think I just want to stay realistic as we're starting. So I'm in a rural area. It's a rainy day. I have a poor connection. My man's demented and his wife is half off the camera. I used your advice about just kind of directing and let's scoot over and this is practice for when you're going to see your nephrologist in a couple weeks. They're going to be using this. This is a trial run. And I just knew that he was breathing and sitting up, and that was good enough for the first time. So I just have to have acceptable standards to just start and do something and make a connection. It'll work itself out.
That's exactly right. That is my mantra. Just get in there and get busy doing it. That's right, Dorothy. I appreciate that.
Of course, our long-term care SNFs are locked down, and I love your idea of making the connection with the social worker or the nurse or DON first by video, because I'm trying to get in there for those patients, and I'm only using phone right now. So that's a great suggestion from today.
Yeah, you can't, I mean, at least for the time being, and we're not taking this technology for granted, it's an actual experience that people can be present to. Like the telephone is almost, we don't even think about our behaviors and how the framework and context and medium of telephone has a ton to do with the quality and character of the communication and the range of possibilities and limitations. We don't even think about that. We don't think about it when we walk into an exam room, or even if we're a home health nurse walking into the home. We sort of forget about the setting and context. For the moment, while this is fresh and new, and for you as potential masters in the future, keeping in line what this actual context and framework and environment is, what it can do, what it can't do, is going to give huge advantages to bring even higher quality of care than people have gotten used to. So yeah, it's a really useful tool. I Okay.
I also want to say, Dorothy, the fact that you jumped right in is huge. And I think that just reflecting on that, like you could have just been like, I don't know, and I can't handle this. This is not working. The Wi-Fi is crappy. But you said, let me stick it out. And I think that that's the message, right? Like, be brave. Always be safe, but be brave. And know that, one time, having a bad day, so a ton of consults, so like 7 of my patients died. And I was just like bummed. I had a family meeting with a family, established goals of care, but the Wi-Fi kept dying. And it was starting to wear on me. I tend to wear my emotions on my face. And forgive the drilling in the background, by the way. I apologize.
Lunch is over.
But lunch is over. But I will say that we had the meeting, did the most in New York State. So it was a most with the patient and the wife. And I said at the end, I really want to apologize. You deserve me to be present and not to be distracted by the Wi-Fi. And he said, I have never, and this was an older gentleman, a vet, and just the coolest dude, but kind of a cranky old man. And he said, I have never had an interaction with a doctor like this. You told it to me like it is, and I know it was tough for you, but now I know what to expect. And it was one of those moments where I was like, it was not my best. I gave it my all clinically, but it was not my best delivery. But I stuck it out, and it ended up being a wonderful experience. And so kudos to you for just sticking it out. And hopefully we'll all have better Wi-Fi in the coming weeks and months.
Well, all I know is that when I start to get upset.
Wait.
Oh, go ahead. Oh, you go, Jennifer. You guys shut me up. That's good.
It always amazes me how quickly the time goes. And we have just about 8 minutes left. So 1 or 2 more questions. If you all want to jump in, this is your chance. The question is, do we need permission to use the modules from Robert Moore for teaching purposes, or can, as far as you know, can we just use them?
Oh, I just stole them from Bob, who publicly presented them as a part of a presentation, and then I acknowledged him on the top saying, thank you, Bob Moore. So yes, they're all publicly available videos produced by a number of educational facilities. You'll decide for yourself whether some are great and some are not so great, but no, you don't need Bob's permission. Although you can tell him I said hi if you do run into him.
Great. So carry on.
Oh, carry on. What was I going to say? I was going to say, oh yeah, when I start to freak out, it turns out the people I'm communicating with also do the same. Like the more I'm feeling myself be upset with the technology, happens every single time, the more upset they become. And the more calm and relaxed and chill I am, well, the more they don't even notice the glitches. It's quite remarkable, right? It's not a surprise, but there it is. So it's the old house of God. The first thing you do in a code is take your own pulse, is manage yourself, manage your own energy. Make it funny when they're fumbling around, laugh it off. Oh my goodness, is that, I can only see half of your husband. Is that his good half? Let's move the camera a little bit. Let's get the camera propped up and get your hands free. Like I work my hands up here in the space all the time I'm using them.
That's a really good point.
Yeah. I'll go, Claritza, because you use your hands too, right?
Oh, I can't. Yeah. It's cultural, but I wanted to say to that point, calling out that this isn't, I wish I could be there in person, but I can't, also can be really disarming, especially for patients who are having like a tough time with the technology. It's always really helpful. It's almost like when there's like patient waits 15 minutes and that's fine, but you come in and you say like, sorry to keep you waiting. And immediately they go like, oh my God, you value me. In a similar way, like, I know this isn't ideal, but it's really important that I'm here with you today. And so I'm glad that we're able to connect through technology. It is really disarming. Patients really take to that. So just to piggyback on what you said, I stole that from a colleague, and it seems to work really well.
So this will probably be the last question. From what you observe, is there a need to get more technology into skilled care facilities? Are there enough iPads, computers, devices to be able to pull this off?
There is a need for more and better technology and acceptance and training for the use of that technology in lots of settings where the most vulnerable folks live, in nursing homes, in long-term assisted living facilities, in small hospitals that don't have the ability to create palliative care resources on the ground. For hospice organizations, home health organizations, these are just tools. They're just a tool that can be used in lots of different ways depending on the circumstances and the desires of the stakeholders, but they need to be everywhere. And the good news is they're almost everywhere already. So it's not that hard to augment them. What's really important that we touched on are the relationships that allow these tools to come out of the toolbox and start delivering value, connecting people to people.
Agreed. And if you were going to invest in something, I'd rather you have a moderately decent tablet, but a really great Wi-Fi. So if you're program developing, the network is the key. So spend a little extra money on that. And it can be a tablet. It doesn't have to be the latest and greatest iPad, as long as it has good audio and video, which most of them actually do. But yeah, there isn't enough of it out there.
Good.
Well, I think we're just about at the end of our time here. Again, thank you so much, Dr. Rios and Dr. Mistler and Dr. Fratkin. As we mentioned earlier, Dr. Fratkin and Mistler are doing a masterclass through the CSU Shiley Institute for Palliative Care. It's a bit more structured than this, more focused on how to actually set up and run a program of telemedicine through your organization. We'll be sending out information about that to all of you. And if you're interested, you can visit our website and sign up on the interest list. But again, thank you all so much. And Michael, last word.
Yeah, no, I want to just reiterate, thank you to the Institute, Jennifer, Damon, Maria, and I think there was Jill is in the background somewhere. Some other people at the Institute made this work. Thank you to Kate Myers for facilitating with the California Healthcare Foundation participation in this project. Thank you to each of you. There's a lot of repeat customers here, I noticed. There's a lot of folks that are familiar to me from prior forums, and I'll miss you. So reach out to me, Michael at ResolutionCare.com. Go to our website, sign up for our newsletter, stay engaged and connected, because this project of transforming the healthcare system is not done in 6 sessions, right? So stay in touch.
All right. Thank you all so much and have a great day.
Bye-bye. Thank you. Thank you, Claritza. Good to see you.